Hi all, hope you're all doing fine. So today's class is going to be about mucormycosis. So mucormycosis is the topic of discussion in India today. So yesterday on 20th May 2021, the government of Tamil Nadu declared mucormycosis as a notifiable disease. So my first question is, how can fungus cause an epidemic? So we all associate an epidemic usually with a bacteria or a virus. So how can a fungus cause a epidemic? So that is the first question that comes to my mind. So for this we have to know in detail about the pathogenesis of mucormycosis. So we have to see the unlikely love triangle between COVID, iron and mucormycosis, and this is going to be the core of the discussion today. So first thing that comes to my mind is, why is the black color? So why is actually the mucormycosis black in color? That is the first question that comes to my mind. And the second question that comes to my mind is, how does it cause the disease? So we'll just come to the black color a little later, because I'm pretty sure you would have all discussed this in the second year of your UG, but we'll come back to it a little later. So quickly about the taxonomy of mucormycosis, it belongs to the subphylum Mucormycosis, order Mucorales, family Mucorrhizae. The Rhizopus oryzae, Delamere and Microsporus are the most common mucors that can be seen. That is it. Nothing else we are going to discuss right now. So the mode of transmission, the most common mode is inhalation, and it can also be transmitted by inoculation directly into the skin and by ingestion of spores. So spores are the transmission medium which enters our body. So once the spore enters our body, how does it cause the disease? The pathogenesis. Okay, so we all know that mucormycosis is ubiquitous. So what is ubiquitous? It is present everywhere. Okay, so the risk factors are, so my question is, if it's ubiquitous, does it mean all of us are at a risk of developing mucormycosis? Is that the meaning of that? No. It is present in the normal air that we inhale. It can be present in the air that you inhale now and the air that I inhale now. But we are not at a risk of developing mucormycosis thanks to our normal defense mechanisms. So who are all at the risk of developing mucormycosis? The risk factors for mucormycosis is diabetes, defect in phagocyte function, elevated level of free iron, and this is interesting, azole therapy. So azole is an antifungal, but patients who are on azole therapy or azole prophylaxis, they are at a higher risk of developing mucor. So we'll just discuss why. So this is the life cycle of mucor. Okay, so the spores enter the body and finally they lead to dissemination. We'll just see how this happens with the help of a scratch board. Okay, so yeah, let me go to my scratch board. So let's just draw a pictorial representation of these spores. These spores, they enter the human body. Okay, once these spores they enter the human body, we are going to just see a normal human body. So it just is attacked like blitzkrieg by this huge cells, this lethal looking cells. What are these? These are the macrophages and these are the neutrophils. So what do? They just attack them from nowhere. Okay, and finally what happens? These spores are phagocytosed and they die a sad death. Okay, so in a normal human being, the neutrophils and macrophages, they just engulf these spores and they die a sad death. This is the reason why you and me, we don't get a mucor every day in our life. Okay, so let's see what happens when the patient is under certain scenarios. Okay, so first let's consider this guy. This guy is a COVID positive patient. Okay, he is taking injection dexa and injection methylprednisolone. Now what happens? So these spores, they enter in, okay? They are just sneaky little bastards, okay? They enter in, okay? Now the phagocytes, they come, okay? But they are not able to phagocyte them properly. Why? Because this injection dexa and injection MPS, they have a inhibitory effect on the phagocytes. So there is defective phagocytes, okay? This is the first concept we are discussing today, okay? So first concept is defective phagocytes, that is caused due to steroids, okay? So defective phagocytes. So what these spores do? These spores, they get very happy, okay? They are all very happy. Let's just make the big happy faces here, and they enter the body system, okay? Now they have entered the body system. Now here is a cell, okay? There is a big cell here, okay? Now the spores are here, okay? Now these spores, they need body parts, okay? They need body parts to become develop hyphae. For that, they have to get into the host cell, okay? So this has to happen, okay? So what happens in a COVID patient? For this spores to enter the body, okay? For this we have to learn two pathogenesis in detail, okay? One is diabetes and second one is increased iron level, okay? So both this help the spores to enter the body, enter the cell, host cell, and help for this to progress into a hyphae, and finally it causes angioinvasion and enters the body. Let's just see how this happens, okay? So in patients with diabetes, okay, there is increased glucose level, okay? So what does this increased glucose level do? It has 5 mechanisms, okay? We're going to see this 5 mechanisms in detail, okay? So first one, it hyperglycates iron sequestering proteins of the body, okay? So let's just imagine this is a transferrin, okay, or a hephaestin, okay? This hyperglycemia does, this hyperglycates this and does not functioning properly, okay? These are all not functioning properly. So there is increase in iron stores, okay? So the mechanism number 1, there is increase in iron stores that is available to the fungi, okay? This I'm going to discuss this in detail when I discuss about iron, but just remember that there is increased iron stores for the fungi, okay? So now let's just finish the iron part. Since I started the iron part, let's just finish the iron part right now. So we all know that, let's just draw GIT here. So iron is absorbed from the duodenum, okay? So it's absorbed from the duodenum. So let's just draw a big cell here. So Fe3 plus and Fe2 plus, it is converted into Fe2 plus, Fe3 plus is converted to Fe2 plus, and it enters the intestine, and there is a DMT transporter here, this Fe2 plus, and there is a hephaestin here and the ferroporitin here. So this hephaestin, this converts this Fe2 plus into Fe3 plus, and this Fe3 plus, this goes and attaches to ferropyridine and it comes out, and then here it is attached to transferrin. So this transferrin, where does it go? It goes to the bone marrow. So there are, what are they there? Transferrin receptors. So it goes there, it takes the iron there. Okay, iron is, now what happens? Iron is, now we just draw a bone marrow cell here. There's a big bone marrow cell here. There's a transferrin receptor here. Transferrin binds to this receptor. It is carrying 2 molecules of Fe3 plus, and it goes here, so Fe2 plus, and it goes here. It is endocytosed. So endocytosed, here there is, what is this? The heme ring, the protoporphyrin ring. So this Fe2 plus and goes and it stays in the center of this, and now this protoporphyrin ring plus this Fe2 plus, this is known as heme. Okay, so this is what normally happens when this heme is degraded in the liver cell. Or in the spleen. Or in the spleen, there are macrophages which degrade the heme and this ferric ion. They are taken up by these macrophages, and there is genes which produce an substance called, this is the main substance we have to know, apoferritin. So what does this apoferritin do? This apoferritin, it binds with iron and forms ferritin. Okay, so apoferritin binds with iron and forms ferritin. This ferritin is the storage form of iron. Okay, so these ferritin, they are stored in the reticuloendothelial cells, usually in the macrophages. Okay, so this is what is happening. Okay, now this ferritin, it is a acute phase reactant. Okay, so what is an acute phase reactant? This acute phase reactant is a substance which is increased whenever there is an inflammation. So what happens in COVID? COVID, there is increased inflammation. So whenever there is increased inflammation, there is increase in ferritin. Okay, so there is hyperferritinemia. Okay, so this is the basic concept you all have to know. First thing is, from the duodenum, the iron is converted first from ferric form to ferrous form, then it enters the cell, it is then converted back to ferric form, it is carried by the transferrin protein, it is carried to the bone marrow cells. There is transferrin receptors which take it inside, and they are bind to the protoporphyrin ring and they become heme. This heme, it is catabolized in the spleen, where it is converted to ferritin, and ferritin acts as the storage form. This ferritin, it is increased as an acute phase reactant in inflammation. So in conditions like COVID, the levels of ferritin is high. Okay, so what does hyperferritinemia have to do with all this? Okay, so we should actually know that every fungi, and for that matter bacteria, needs iron. Okay, So every fungi or bacteria, it needs iron. Okay, so they contain some substances called siderophores. Okay, so siderophores, what they do is they help the iron to enter the fungi. Okay, so the iron to enter the fungi. So whenever there is increased iron, the every fungi, especially mucor, it loves it. Okay, so mucor increases this. So let's see this beautiful vicious cycle where COVID increases ferritin, and this ferritin actually forms a fertile soil for mucor. Okay, and COVID does not does this alone. It also reduces diabetes, which also forms a fertile soil for mucor. Okay, so now we have seen how iron helps in providing a fertile soil for mucor. Okay, it helps in activating this mucor. Okay, so we have seen, just we'll come back to and finish rapidly the other mechanisms by which diabetes causes mucor. Okay, so there is this pose here, they want to enter the cell, and what diabetes does is there is a protein here. Okay, this is known as GRP78. Okay, this GRP78 helps this pose to enter the cell. Okay, so enter the human cell, and GRP78 in the expression, it is elevated by diabetes. So first we saw that it increases the iron sequestration. Now we saw that diabetes increases the cell expression of GRP78, which helps in this entering the cell. And diabetes by itself causes phagocyte dysfunction, which we already saw how it causes worsens the mucormycosis. So this we have seen. This is the third pathogenesis. Okay, fourth pathogenesis is COTH, which is also a protein which helps in increased fungal growth. Okay, so one, we saw about iron sequestration. Two, we saw about GRP78. 3, we saw about phagocyte dysfunction, and 4 is finally COTH expression. Okay, so these are the ways in which diabetes increases mucormycosis. So we know that COVID and diabetes have a close relationship, which we saw in the last class. Okay, so if you want, you can just go back and see the class, the relationship between COVID and diabetes, and hence this causes mucormycosis, and this mucormycosis, the pathogenic mechanisms are all this. Okay, now to the final point, just a final quick point. Okay, so final point is mucor plus acidosis. So acidosis, we know that beta hydroxybutyrate is the most common cause of acidosis in a diabetes, in a DKA. This beta hydroxybutyrate, this increases the fungal receptors and increases the fungal adherence. Okay, so this acidosis can also cause increased mucor. Okay, so finally, to summarize, hyperferritinemia, diabetes, and acidosis. Okay, these are a deadly combination which causes increased mucormycosis risk. Okay, so this is the pathogenesis of mucormycosis. Okay, now just let's fastly come back to our PowerPoint, where Here we see the macrophages and neutrophils. It comes, this iron gets sequestrated, and we can see that this is inhibited by glucocorticoids. The phagocytization is inhibited by glucocorticoids and neutropenia, and hyperglycemia, iron overload, glucocorticoid and neutropenia, it causes acquisition of free iron by the hyphal proliferation. Okay, and here it's a detail. This picture I wanted to show just for this GRP78, which expression is increased, and this causes the fungal elements to enter the cell, and also about COTH. So these two are something we already discussed. Okay, and this is something very similar of how iron helps in sequestration of the fungal elements. Okay, and this is the difference between a normal host. This is us. Okay, this is when the immune system is totally compromised. This is what happens. Okay, now just quickly I want to see what happens after all this. Okay, so the hallmark of mucor is always angioinvasion. So angioinvasion, hemorrhage, thrombosis and necrosis. This is very important. Okay, this is the hallmark of mucormycosis, and this is the cause why it is very deadly, because it can spread to any part of the body. That is why it is deadly. Okay, so dissemination is the final deadly complication of mucormycosis. Okay, so here we see it again. Okay, fungal growth overwhelms, disseminates via bloodstream and direct invasion of it. So angio-invasive growth. Okay, this is one term you have to remember again and again, angio-invasive growth. So we talked about those three most important risk factors and angio-invasive growth. Now just to summarize, in COVID there is type 2 diabetes and hyperglycemia, which is again a risk factor, hyperferritinemia, acidosis, which can be either associated with diabetes, or it can be a respiratory acidosis due to prolonged ventilation, and immunosuppression with steroids or tocilizumab. Okay, which is an interleukin 6 inhibitor. Okay, so the targets of treatment with this basics, actually the treatment always depends on pathogenesis. When we have a proper understanding of pathogenesis, then the treatment becomes easy. Treatment is not something I'm going to deal with in this class. Probably I'll take another class to discuss about treatment. But treatment is about rapid initiation of antifungals. This is very important. The antifungals need to be started as soon as possible, as soon as we have a suspicion. And amphotericin. Okay, amphotericin, there are 3 different varieties of amphotericin, which we'll discuss detail in the next class. Azoles, fosconazole and ispaconazole. This also will be dealt in detail in next class. And correction of the risk factors. So diabetes, immunosuppression and hyperferritinemia, this needs to be corrected. Okay, and finally excision if possible. So we need to excise the tissue. That is also a part of the treatment. So it's a surgical plus medical management is required. Okay, and the challenges in treatment we'll deal in the next class. Okay, thank you. You can ask any doubts, you can put it in the comment section. Thank you.